Good morning and a very warm welcome to you all. My name is Nens van Alphen. I'm an associate professor of neurology and I'm the local host and organizer of the 2021 online ICCNMI course and conference. We are very happy to announce that we've made a very special addition to this conference with the help of Cadwell, who have sponsored and taken care of a very interactive live demo session in 3 continents of the world for you. You can find out more on this webpage, which also has the access link for all 3 sessions that you might want to attend. These are free live online demos and with an interactive component, so you can ask anything you like and your local host will try to show this to you. Here are the sessions. We've set one up in Asia, coming from Singapore. We've set one up in Europe for you, coming from Rome and Italy. And we've set one up for the Americas, coming live to you from Sao Paulo in Brazil. All the sessions are geared towards your lunch hour in the local time zone. Obviously, you can also watch them from other parts of the world. Now let's see our speakers. We've got 3 renowned hosts who are very experienced neuromuscular ultrasound scanners themselves. In the Asian session, Dr. Joy Vijayan will come to you from Singapore, demonstrating you his techniques and take on neuromuscular ultrasound. In Europe, we've got the honor to meet the founding father of the ISPNI Society, Luca Padua, who will teach you from his office in Rome everything he knows about scanning. You can just ask him for any special tips and tricks. And finally, in Americas, Dr. Ana Lucila Moreira from Sao Paulo, Brazil, will be your live host and show you any technique that you might want her to demonstrate. Incidentally, she will also be the next year's host of the ICCNMI 2022 event, so please watch out for that as well. So join us for these free live demos brought to you by the ISPNI in cooperation with Cadwell. You can access them from these links below. If you're interested, you can also still subscribe to the full conference, and the digital material will also be available offline after the event ends. We sincerely hope we can meet you there, and happy scanning, everybody.
Are we good to go?
Yes.
Good morning. My name is Dr. Joy. I'm a neurologist working at the National University Hospital, Singapore. At the outset, let me thank the organizing committee of the ICCNMI and in particular Dr. Van Alphen for inviting me to give this talk for this session. So it's quite unfortunate that we had to do it over Zoom, because if you see patients and do things real time with a hands-on kind of interaction, you would be learning much better. But unfortunately, with the ongoing pandemic, I think what the organizers are doing is quite commendable, in the sense they're trying to make it as useful for the participants as possible. So what I plan to do is, I also need to thank the sponsors, especially from Cadwell. I have Michael here and Anita here, who have been helping me out with this session for the past few weeks. So I would be calling Michael in between to help out with the knobs. And Anita also has kindly agreed to be the model for the session. Okay, so what I plan to do is, initially I would just take you briefly, I would give you a brief overview of what we are doing with ultrasound. Then I'll share some PowerPoint slides, and then of course I'll go back to live demonstration of the various nerves and muscles of the upper limbs and lower limbs. Unfortunately, we don't have any patients, again, like I said, because of the ongoing COVID. The access to patients are quite restricted here in Singapore. Okay, so let me just start off with the anatomy of the upper limbs. Okay, so imaging is actually what you actually do is finding out whether anything is wrong with the anatomy. Okay, so you're doing a morphological analysis of the muscles and nerves of the upper limbs. So you have to be very quite good with your anatomy. Okay, so that's a very fundamental aspect of being a nice sonographer, being very, very good with your anatomy. So let me just give you a brief overview, because there'll be many novices in this audience who may not know much about ultrasound. So what I would do is start off with very basic anatomy and then come up, talk about more complex aspects of peripheral nerve ultrasound. Okay, so we have Anita here. So you have the cervical spine, and from the cervical spine you have the brachial plexus which comes out. Okay, so basically it comes out from the posterior triangle of the neck. You have the sternocleidomastoid here, the trapezius here, and the clavicle here. So that's where the posterior triangle of the neck is. And in this triangle you have the scalenus anterior and the scalenus medius, which forms the floor of the triangle. And between these two muscles you have the brachial plexus which comes out, the C5, C6, C7, C8, T1 roots. They come down, and in the supraclavicular area they clump together to form the trunks and roots. And further down, just behind the clavicle, they split to various divisions, and then in the axilla they form the cords, and then they go down the extremities as the various peripheral nerves. So cervical spine, posterior triangle, interscalene space from which the various roots come out. They form the brachial plexus. You have the trunks, and then the division, and then you have the cords and the peripheral nerves. Okay, so I'll give you a brief overview just based on surface anatomy, and then later I'll take the scanner, and then I'll show you the various structures. Okay. Now this is the neck and the supraclavicular space where the brachial plexus is. Then of course you have the upper limbs. So the upper limbs, you have the arm and the forearm and the hand. So in the arm you have the deltoid muscle, which forms the main abductor of the shoulder, and then you have the flexor compartment here where you have the biceps brachialis and coracobrachialis, and behind, that is the posterior aspect of the arm, you have the extensor compartment where you have the three heads of the triceps, and lower down you have the anconeus. Okay, whereas in the forearm, again the flexor compartment is mainly the median innervated muscles. Okay, and then the extensor compartment you have the radial innervated muscles, and the hand, mainly the about 20 small muscles in the hand, which are predominantly innervated by the ulnar nerve. Okay. Now let me start off with the sorry. Okay, let me start off with the arm. I'll show you the biceps, deltoid, the triceps, and various muscles of the upper limb, and then I go down. I'll show you the nerves too. Okay, so this is a scanner. So you can see my screen. I'll be talking about the various applications that we have when we do a nerve ultrasound, that I'll be doing when I do the PowerPoint presentation, and the importance of these things. Okay, so this is a 4 to 14 megahertz probe. I think you can see it. Okay, it's a 4 to 14 megahertz probe, quite good linear probe. It's good in assessing both the superficial structures predominantly as well as the deep structures. Okay, so let me start off with the deltoid. Okay, so this is the deltoid muscle. You can see the humerus and the deltoid muscle. Okay, and what you actually see is that you can see these dark surfaces, or the hypoechoic area, which are actually the muscle fibers, and in between you see the septations. Okay, these septations they appear hyperechoic. Okay, so you have these white bands in between these dark spaces. Okay, so this actually gives you a what we call a starry sky appearance. Okay, and then you go down. So it's very important that you have some understanding about the architecture of the muscle. So there are many different types of the muscles, can be divided into different types based on the architecture. So you have pinnate muscles, you have unipinnate muscles, bipinnate muscles, multipinnate muscles. So different types of pinnations, and this deltoid muscle is a multipinnate muscle. So you have multiple bands from which muscle fibers come. Okay. So these are the pinnate muscles, and now this is the biceps is a strap muscle. So it's a long funicular muscle, and the triceps also similarly, it's a long muscle. Okay. Whereas the muscles of the hand, again, they are pinnate muscles. Okay, so this is the deltoid muscle, and like I said before, you can see these white bands, and this one right on the top is the epimysium. Okay, right on the top, and above that you see the subcutaneous plane. Okay, and here you see the various septations. Okay, I'm going down, and the muscles actually they are separated by these hyperechoic areas. Okay. So this is a biceps. You can see the screen, both the video screen where the probe is placed on Anita's biceps, and then of course you can see the ultrasound screen also. So this is a biceps. So I'm going down, and here you basically have two muscles below the biceps, which is the coracobrachialis and the brachialis. Okay, and then when I go posteriorly, you have the triceps muscle. Okay, so triceps muscle, there are three heads: medial head, lateral head, and long heads. Okay. So when you start off doing ultrasound, it's very important that you learn and understand how the muscle architecture looks. Okay, it's important because if you are able to identify the muscle, it can be very useful when it comes to doing EMG studies, or if you want to administer Botox, or any kind of intervention. It would be very useful if you know the various types of muscles that you can see. Okay, so now, like I mentioned before, the posterior aspect of the arm, or the posterior compartment, you get the triceps, and here you have three muscles, which is the biceps, brachialis, and the coracobrachialis. Okay, so one thing you need to understand is that the biceps and the triceps, it can be quite difficult to differentiate the various muscles because they all have the same action. What I normally do is I keep the probe on the muscle, and then this is shortened. The screen has become smaller.
By mistake, I think.
Oh. Sorry for that. I'm just going to. Okay. So this is the biceps, and like I mentioned before, it can be sometimes quite difficult to make out the various muscles because all of them have the same action. It is basically flexion of the at the elbow. Okay, so I'm asking Anita to flex her biceps. When you flex your elbow, you can see the muscles contracting. Okay, so you go distally, and if you're able to make out a plane between a very distinct plane between the muscles, that would be the demarcation between the biceps and the brachialis. Okay. Whereas the triceps is the same thing. There are three heads. It can be difficult, but unlike the biceps, the three heads of the triceps are fairly localized. You know that the lateral head is placed, it's in the lateral aspect of the arm, whereas the medial head is in the medial aspect of the arm. Okay, so going down, so I'm just applying some gel. Okay, so this is the you can see the forearm muscles, and I will just come to the various muscles. So that's up here is the pronator teres, and you can see the pronator teres, and you can see this facial plane which goes between the two heads of the pronator teres. So this is where the median nerve is. So I'll be coming back to the anatomy of the median nerve. a little bit later, but I just wanted to show you the two heads of the pronator teres. Okay, so here also you could ask the patient to activate the muscle. Can you push instead? Pronate the other way around, like this.
Oh,
Turn your
this
wrist. Yeah, and you can see the muscle contracting. Okay, and lower down, when you go down, of course you have the flexors of the fingers and the hand. So basically the main muscles here are the flexor pronator teres, the flexor carpi radialis, the palmaris longus, and the flexor digitorum superficialis. Okay, so here what I'm going to do is ask Anita to flex her fingers, and you can see that these muscles possibly they are the flexor digitorum superficialis. Okay, and here of course this is a pronator teres, but lower down this is the flexor digitorum superficialis. Okay, and then lower down, when I go to the lateral aspect or the radial aspect, that's where you see the flexor pollicis longus. Okay, so I'm going to ask Anita to just bend her thumb, and you can see, so that's the flexor pollicis longus. Okay, now I'm going a bit medial to the ulnar aspect. I'm going to ask her to flex a little finger, just the tip. Okay, so on flexion of the distal interphalangeal joint, you can see that the pronator teres is contracted. Okay, so these are the muscles, main muscles of the forearm, and you go down, you can see the pronator quadratus. Okay, so this is a transverse muscle which goes across the ulna and radius. Okay, so this is the pronator quadratus, and all the muscles above them are the long flexors of the fingers, which is the FDS, flexor digitorum superficialis, and the FDP, which is the flexor digitorum profundus. Okay. Now you go to the medial aspect. I'm going to ask Anita to clench make a fist, and then flex at the wrist. Okay, so here is where you have the flexor carpi ulnaris. Okay, so the flexor carpi ulnaris and the flexor digitorum profundus to the ring finger and the little finger, they are supplied by the ulna. Okay, now coming to the extensor aspect. Okay, so the extensor aspect is where you have the extensors of the wrist and of the fingers, and these muscles are supplied by the radial nerve. Okay, so the most proximal muscle, of course, is the brachioradialis, and then you go distally, you see the extensor carpi radialis longus and extensor carpi radialis brevis. Okay, so for the brachioradialis, I'm just going to ask Anita to semi-pronate with your hands like that. Can I get you to flex at your elbow? And you can see that it's contracting. And lower down, when I go distally, I see the extensors of the wrist, which is the extensor carpi radialis longus and extensor carpi radialis brevis. Okay, so I'm going to fix her forearm down, and I'm going to ask her to extend at her wrist. Okay, down, extend, down. Okay, now further down you have all the smaller muscles. Okay, so mainly you have the extensors and abductors of the thumb. Okay, so you can see Anita's thumb here. So I'm just going to ask her to extend her thumb. This is okay, now it's abduction, abduct. Okay, relax, abduct, relax, abduct, relax, abduct. Okay, so you need to manipulate the probe to see which muscle is moving the most. Okay, abduct. So you can see it's that. Okay, and you should be also aware of the plane of the muscle. Okay, so it actually from the thumb it goes to the lateral epicondyle. Okay, so you should be knowing that plane and the direction of the muscle, so that you can easily pick up which muscle it is. Again, I'm going to ask her to extend. Okay, extend, extend. Okay. Now, can I get you to do this behind? The other way around, against me. Yeah. So this is the extensor carpi, the extensor pollicis longus and the extensor pollicis brevis. Okay, and then the superficial extensors, which is the extensor digitorum communis, which extends at the metacarpophalangeal joint, and then distally you have the extensor carpi ulnaris, like that, and the extensor digiti minimi. So you can see that beautifully contracting this one. Okay, so just to recap, you have the flexor compartment, which is mainly median innervated muscles. You have the superficial group of muscles, which is the pronator teres, the flexor carpi radialis, the palmaris longus, the flexor digitorum superficialis, and the deeper muscles, which are the flexor digitorum profundus and the flexor pollicis longus and the pronator quadratus. Okay, so these muscles, the deep muscles, actually they are supplied by the anterior interosseous nerve of the median nerve. Okay, so that is it's important to know about these muscles, because if you have a selective involvement of the anterior interosseous nerve, what you see is that there will be some change in echogenicity of these muscles which are supplied by the anterior interosseous nerve. Okay, so again to recap, flexor compartment of the forearm, you have the pronator teres, which is the main, which pronates the forearm when it is kept extended, and you have the flexor carpi radialis, flexor palmaris longus, flexor digitorum superficialis, and the deep muscles, which is a flexor pollicis longus, flexor digitorum profundus, and the distally, which is the pronator quadratus. Okay. Now on the extensor aspect, which is radial innervated muscles, you have the most proximal, which is the brachioradialis. Then you have the extensors of the wrist, which is the extensor carpi radialis longus and brevis, and supinator muscle. That's a muscle which I did not mention before. So this is a supinator muscle which is closest to the radius. You can just see it. This muscle which curves around the radius is the supinator muscle. Okay, and then posteriorly, when I go posteriorly, you can see me twisting the probe, changing the direction of the probe. And on the extensor aspect, you have several muscles. So how you actually divide them is muscles to the thumb and the index finger, which is the abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, and the extensor indicis. So the extensor indicis is also a muscle that I can show you. Can you extend your index finger? Okay, so you can see that muscle which is contracting the most. So this is the extensor indicis. When you go proximally, you can see that it's contracting. Okay, so this is important because, you know, if you're able to delineate or identify these muscles, it can be of tremendous use in giving Botox and doing EMG sometimes, or planning things like muscle biopsy and all those things. And so those are the four muscles to the thumb and the index finger. And then you have the more superficial muscles, which is the extensor digitorum communis, and the muscles which go to the medial aspect of the hand, which is the extensor carpi ulnaris and the extensor digiti minimi. Okay. Now let's go to the hand muscles. So the hand is actually, there are you can look at the hand, the video of the hand here. You have the thenar eminence, you have the hypothenar eminence, then you have the dorsal interossei in the spaces, intermetacarpal spaces, and you have the palmar interossei. Okay, so when I keep the probe on the thenar eminence, you can see this white hyperechoic structure. This is actually the tendon of the flexor pollicis longus. Okay, so I'm just going to ask Anita to again flex her thumb at the digit here, like that, interphalangeal joint. You can see that there's some movement of the tendon. Okay, so that's a flexor pollicis longus. And superficial to this tendon is actually the abductor pollicis brevis and the opponens pollicis. And inferior or dorsal to this is actually the flexor pollicis brevis and the adductor pollicis. So the adductor pollicis is actually a muscle, again like the pronator quadratus. You can see that it runs transversely, not longitudinally. Okay, so it runs across the plane of the hand, not along the plane of the hand. So if I were to ask Anita to again activate her muscles, can you bring this up towards the ceiling? Okay, up, up. You can see that it's contracting. Okay. Now flexion. Can you bring your thumb towards? Okay, towards. Okay, so you can see this muscle contraction. Okay. So how you actually identify the muscle is to ask the patient to activate that muscle and see where the movement is the maximum, and that's how you actually are able to name the muscle. Okay, so you go to the hypothenar eminence, and again here you have 4 muscles: the abductor digiti minimi, the opponens digiti minimi, the flexor digiti minimi, and the palmaris pelvis. Okay, so here you can see in between the metacarpal bones, you can actually see the palmar interosseous. Okay, so I'm going to ask her to adduct, abduct your fingers, adduct. You can see. Okay, so you can see some movement of the palmar interosseous. Okay, so this is how you identify the muscles. And above these muscles, you can see these circular hypoechoic structures, which are actually the long tendons of the hand. Okay. Now the dorsum of the hand, that's where you see the dorsal interosseous. Okay, so I'm just going to apply some more gel. So you can see those muscles, abduct, adduct. Okay, so you can see the movement there. So these are the dorsal interosseous. Okay, so another important thing you need to understand, these muscles are we usually don't EMG these muscles. So by doing an ultrasound, you can actually find out how the architecture is, whether there's any wasting and all those things. Okay, so these parts of the hand, especially the dorsum and the palmar aspect of the hand, are extremely painful when you do EMGs. So by doing ultrasound, you can actually find out how these muscles are in terms of its anatomy, whether there's any wasting, or in terms of its architecture, whether there's any inflammation or fibrosis or fatty replacement. Okay, now that we have spoken about the muscles, let me go to the nerves. Okay, so like I was mentioning before, the upper limb is supplied by the brachial plexus, C5, C6, C7, C8, T1, and these join together. The C5, C6 joins to form the upper trunk, C7 continues as the middle trunk, and C8, T1 is the lower trunk. Okay, and these trunks, they divide into divisions, anterior and posterior. The anterior of the upper two, they form the lateral cord. The anterior continuation of the anterior division of the lower trunk is the medial cord, and the posterior divisions of all 3 trunks form the posterior cord. Okay, so that's actually quite difficult to see because these divisions are behind the clavicle, and you won't be able to access these divisions using an ultrasound probe. Okay, but in the axilla, where you can actually see the peripheral nerves, it's quite easy if you know the anatomy. Like I said before, the cords as well as the various roots, the cords as well as the various peripheral nerves can be identified based on where they're located in relation to the brachial artery and axillary artery. Okay, so let me start off with the median nerve. So I'm going to start off distally, and then I'll be coming proximally. Okay. 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 So it's very essential that you are very definite with what you're seeing. Okay. So when you go towards the distal aspect of the hand, you would see many ovoid structures. So it's quite easy to get confused whether it's a nerve or the other ovoid structures being tendons. Okay, so you can see that this one where my pointer is, that's a median nerve. Okay, so what you need to do is, number one, you can see the fascicular architecture. It has a honeycomb appearance. Okay, I'm going to freeze the screen. Okay, and you can see that the median nerve, they will have a honeycomb appearance. This honeycomb appearance is because the fascicles are hypoechoic, and around these hypoechoic fascicles you have perineurium, which is hyperechoic. Okay, so you actually get a very honeycomb pattern when you look at the nerves. Okay, whereas this is not seen with tendons. Okay, tendons, they are more hyperechoic. They don't have a honeycomb appearance, and then you have what we call this flashing light pattern. Okay, so when you toggle the probe, you can see that the tendons, they become bright and dark, so like a flashing light, whereas the median nerve, it doesn't change in terms of its echogenicity, it remains the same. Okay, so these are the tendons which goes into the hand, and when I go proximally, you can see the median nerve diving deep. Okay, so it's diving deep, and more importantly, what you see is that the nerves always, they remain in the facial plane between muscles. Okay, so this is a facial plane between muscles, and the nerve is located there. Okay, so if you were to ask me what muscle this is, based on the direction of its fibers, I think it's the proximal aspect of the, no, this is the pronator quadratus. So if you're confused as to what muscle it is, just ask the patient to activate that muscle. Flexion. Okay. Okay, so it's a pronator, I mean it's the flexor digitorum profundus. Okay, so here on the radial aspect, this one, so this is a flexor pollicis longus. So you have the median nerve which sits posterior to the flexor digitorum superficialis and in the space between the flexor pollicis longus and the flexor digitorum profundus. Okay, so this is the median nerve, and I'm going proximally, and you can see that the median nerve is becoming more and more deep, and then it goes, you need to see the video also with regards to where I'm placing my probe and how I'm changing the direction of the probe. You can see that when I go proximally, the median nerve actually dips, and then it takes a oblique course. That's why you have a change in the shape of the nerve. From ovoid, circular, it becomes more longitudinal. You can see that. So that's the two heads of the pronator teres, and then you can see that it's going up to the arm. So now I'm in the arm, and the nerve is lying close to the medial to the brachial artery. Okay, so that's a median nerve. So distally between the two heads of the pronator teres, I'm going distally. Then it goes in the plane between the flexor digitorum superficialis and the two muscles which are supplied by the interosseous nerve, which is the flexor digitorum profundus and the flexor pollicis longus. Okay, and distally, now you can see the pronator quadratus. Okay, so again, to show you the median nerve, my arrow is going to be placed on the median nerve. Okay, you can see that it's going dipping down between the various muscle planes, then it's going up between the two heads of the pronator teres, and then this is where it's located in the arm, and this muscle which is posterior to the median nerve in the arm is the brachialis muscle. So what you can do is you can ask her to flex elbow. Okay, you can see that it's contracted. Okay, so this is a brachialis muscle. Okay, so I'm going proximally again, and you can see that the median nerve from medial aspect becomes a bit more lateral to the brachial artery. Okay, so I'm just going to ask Anita to abduct her arm, and you can see again, you can see that how the direction of the median nerve is changing in relation to the brachial artery. From medial, it's becoming lateral. Okay. So that's about the median nerve. Okay. So the median nerve is very important because it is the main nerve to the thumb, and then it is the main nerve to the flexors of the forearm. Okay, so it helps in flexion of the forearm, flexion of the wrist, and with the abduction and opposition of the thumb. The other function, of course, is the pronation of the forearm. Okay, so median nerve is basically concerned with pronation of the forearm, flexion at the wrist, and opposition and abduction of the thumb. Okay, so I'm going again distally. You can see the median nerve. It's sitting on the brachialis muscle. It comes distally. It goes in between the two heads of the pronator teres, and then it goes inferior or posterior to the flexor digitorum superficialis, where it sits in the space between the flexor digitorum profundus and the flexor pollicis longus. Okay, and then distally it enters the hand. So I'm just going to show you the carpal tunnel, because this is the median nerve entrapment at the carpal tunnel. Carpal tunnel is commonest entrapment neuropathy. So you need to know some anatomy of the carpal tunnel. Okay, so I'm just going to zoom, increase the depth. Okay, so now you can see. Okay, so I'm just going to, if you're unsure as to which the median nerve is, just toggle like that and see which structure is not changing in echogenicity. So this is the one. And then secondly, you just need to see whether it's got a fascicular pattern or the honeycomb pattern, and you can see that it has got a honeycomb. So this is the median nerve. Okay. So here, this hypoechoic structure which goes above the median nerve is the flexor retinaculum. Okay, and you have the various tendons which are seen in the carpal tunnel. There are actually 9 tendons. One is the flexor pollicis longus, and 4 tendons of the flexor digitorum superficialis, and 4 tendons of the flexor digitorum profundus. Okay, so that's a median nerve. It enters the carpal tunnel along with the 9 tendons, one of them being flexor pollicis longus, and 4 to FDS and 4 to FDP. Okay, and you can again identify the tendons. If I were to ask Anita again to, so this is the flexor pollicis longus. Okay, so this is the flexor pollicis longus. Okay, and now you can see this hypoechoic structure just above the median nerve, which runs like that. That's the flexor retinaculum, and the structure just above that is actually the tendon of the flexor carpi radialis. Okay, so it is a tendon which goes outside the carpal tunnel. Okay. Now another important thing is that you need to also find out where the myotendinous junction is. So the flexor digitorum superficialis and the flexor digitorum profundus, as they go distally, these muscles, they become thinner and thinner, and they become the tendons which enters the carpal tunnel. Okay, so this myotendinous junction is important because sometimes in some patients there's distal extension of this myotendinous junction, and the muscle can actually be inside the carpal tunnel, which can cause, which could be the reason for the carpal tunnel. Okay, so you need to see where the myotendinous junction is. Okay, now this is about the content of the carpal tunnel, which is the median nerve and 9 tendons, and then you have the flexor retinaculum which goes on top, and then you need to know the borders also. Okay, so medially, if you go, to the radial aspect, you go. It is actually there are 4 bones, 2 laterally and 2 medially, the scaphoid pole and the tubercle of the trapezium. Okay, so this is the tubercle of the trapezium and this is the scaphoid bone. Okay, so that forms the radial wall of the carpal tunnel. So 2 bones, proximally it's a scaphoid, distally is the trapezium. And then when you go towards the ulnar side, it is actually the pisiform bone and the hook of the hamate. Okay, so the pisiform bone and the hook of the hamate. Okay, so let me just focus on this. So let me just focus on this flexor retinaculum. You can see my arrow. You can see it's a thin hypoic structure which is quite, it runs like a line. And when I go to the medial aspect, you can see it dipping underneath this vessel, which is pulsating, which is the ulnar artery. And just above that is the ulnar nerve. Okay. So the flexor the flexor retinaculum, it actually forms the floor of the Guyon's canal. Okay, Guyon's canal is where the ulnar nerve enters the hand. Okay, so the flexor retinaculum is about 4 cm when it comes to the proximal to distal dimension, 4 cm, and when I'm going into the hand, you can see that the probe is going into the hand. You can see that the median nerve, it actually splits into 2. Okay, so it splits into the radial and ulnar branches, and the radial branch, just prior to that, sometimes if you are fortunate, you can see the recurrent motor branch which can be seen going to the abductor pollicis brevis. Okay, in this case I'm not able to see, but when I'm keeping the probe on, the arrow on the median nerve, you can see when I go distally, the median nerve splits into 2, and then again it splits into many different common digital nerves and proper digital nerves, which goes and supplies the skin of the lateral 3 fingers. Okay, so that's about the median nerve. So let me show you the median nerve again from distal to proximal. So you can see the median nerve honeycomb pattern, and when I go proximally, this is the median nerve. Okay, when I go proximally, you can see it diving deep, and then it's going between the 2 heads of the pronator teres, and then it goes and joins the brachial artery where it runs medial to the brachial artery, and then when it goes proximally, the median nerve from medial, it becomes lateral. Okay, so here distally the median nerve is sitting on the brachialis muscle. Okay, and then the median nerve comes distally between the 2 heads of the pronator teres. Okay, now if you look at the sites of entrapment of median nerve, the commonest is carpal tunnel. Okay, but there are some proximal entrapment sites also. One of this maybe you must be familiar with is the ligament of Stuthers, which actually there's a spur, there's a bony spur which is seen in the medial aspect of the humerus. Okay, and from there's a ligament which goes to the medial epicondyle, and the nerve goes below this ligament, and then you can get entrapment there. Then as I go distally, the biceps tendon, it goes and attaches to the Lacertus fibrosus, so the bicipital aponeurosis. So the median nerve actually goes underneath the bicipital aponeurosis, somewhere here. So it should be somewhere here. So that's a second potential site. So first one is ligament of Stuthers, which of course in Anita it's not there. And when I go distally, it can be the entrapment below the bicipital aponeurosis. Then between the 2 heads of the pronator teres, when it is called the pronator teres syndrome. And then distally, when I go distally, it can get entrapped between the 2 heads of the flexor digitorum superficialis. Okay. So few potential sites of compression which you should be aware of, because once in a while you see patients who come with a proximal median neuropathy, and you should know where the site of entrapment is. So again, to recap, ligament of Struthers, bicipital aponeurosis, between the two heads of the pronator teres, and lower down between the two heads of the flexor digitorum superficialis, and finally the carpal tunnel. Okay. Now, in carpal tunnel, what basically happens is this nerve, it becomes thickened. Okay, there's enlargement of the diameter of the median nerve. So normally we take it as 0.10 centimeters. So there's enlargement of the median nerve more than, I would say, 10 millimeters. If it's more than 10 millimeters, we call it as the nerve is enlarged. Okay. Then the other thing is you may have to look at the fascicular architecture. If there's loss of fascicular architecture, it may mean that there is some kind of neural edema which is associated with carpal tunnel. Okay. And finally, you should also look at whether there's any change in the caliber of the nerve. Okay. So sometimes when you go distally, you see that there's a sudden constriction of the median nerve. Okay. So from 10 millimeters, it goes down to about 6 millimeters, and once inside the hand, it becomes again 10 millimeters. So there's a focal constriction or focal narrowing, which is again a sign of carpal tunnel. Okay. So these are the things you need to look with regards to the nerve, but it is also important that you look at the surrounding structure. So in carpal tunnel, what happens is there's an upward bowing of the the flexor retinaculum. It's pushed up. Then you should look for any changes of the tendons within the carpal tunnel. So sometimes you can get tenosynovitis of the tendons, and these tendons, around these tendons, you can see a hypoechoic fluid rim. Okay, so that is also an indication of tenosynovitis and could be a reason for the carpal tunnel. Okay. Then, like I mentioned before, you need to look at the myotendinous junction. Where is it terminating? And lastly, sometimes what happens is that when you go distally, you can see that you have these lumbrical muscles which arises from the tendons of the flexor digitorum profundus. So sometimes when you flex the hand or the fingers, you can get these lumbricals are pulled back into the carpal tunnel. So that is called the lumbrical intrusion. Okay, so it's pulled back into the carpal tunnel, and you can have median neuropathy. Okay, so it's not only knowing about the size of the nerve, the architecture of the nerve, but you should also carefully look at what is happening around. Okay, then of course you should also pay attention to the floor of the carpal tunnel. You have all those carpal bones, so if there's any arthritis, inflammation of those bones, again there can be secondary compression of the median nerve. Okay. Now let me talk about the ulnar nerve. So I've spoken all about the median nerve, where it comes from. It comes from the lateral and medial cord to form the median nerve, and then distally there are few sites of compression. Then you should know the various muscles supplied by the median nerve. Yeah, and one thing which I did not mention is the anterior interosseous nerve. Okay, so the median nerve, from the median nerve you may have a very small branch which is anterior interosseous nerve, which you may not be able to see always. In this case, I'm not able to see it, but again, like I mentioned before, you can get some clues if the anterior interosseous nerve is injured, because you can look for any change in echogenicity within the muscles supplied by the anterior interosseous nerve. But the other thing is that you can see these two bones, the radius and the ulna. So this is the interosseous membrane. Okay, and this is the interosseous artery. So the median nerve is located just close to that blood vessel. Okay, so it is enlarged in patients who have any inflammatory conditions to the anterior interosseous nerve, or if there's any focal compression. That's a situation where you can actually see the anterior interosseous nerve. Otherwise, it can be quite difficult to make out. Okay, but pay attention to the muscle it supplies and pay attention to the interosseous membrane. Look for the blood vessel there, the interosseous artery, and the nerve is usually located adjacent to the nerve. Now let me go to the ulnar nerve. So the ulnar nerve is a direct continuation of the medial cord. So the medial cord comes from the lower trunk. So C8, C5, C6, C7, C8, T1. C8, T1 forms the lower trunk, and the lower trunk divides into anterior, posterior. The anterior division of the lower trunk, it forms the medial cord. Okay, so if you want to identify the nerve, like I said, look for fascicular architecture. And there are some sites where the nerve can be easily identified. For example, the median nerve, it is at the distal disc crease, just proximal to the carpal tunnel. For the ulnar nerve, if you have doubt in identifying it, you just look at the cubital tunnel. Okay, so this is the elbow, and here you can see the olecranon, and here you can see the medial epicondyle. Okay, so this space between the olecranon and the medial epicondyle, this curvilinear space, okay, is the cubital tunnel. So just place the probe there. Okay, and you can see this ovoid structure. You can see this. That's the ulnar nerve. Okay. And one catch with regards to the ulnar nerve here is that you may not see the fascicular architecture. There's no honeycomb appearance. It becomes more obvious when you go distally, but within the cubital tunnel, or within proximal to the cubital tunnel. Okay, so proximal to the cubital tunnel here, you may not get that fascicular architecture because at this area, what basically happens is there's not much of connective tissue within the nerve. Okay, so they all appear as one homogeneous big fascicle. Okay, but when you go distally, there's a lot of perineurium, a lot of connective tissue, and the nerve divides into several fascicles. Okay, but proximally, it tends to become more homogeneous, and you may not be able to find a honeycomb pattern. Okay, so this is above the elbow. You can see the position of my probe. So I'm going proximally. So this is ulnar nerve. Okay, and you can see its relationship to the. Let me just check on it again before I confirm. Okay, yeah. Now you can see the brachial artery. So I'm going to apply some pressure. You can see the brachial artery pulsating. So this is located medial to the brachial artery. If you go there, you can also see the median nerve. Okay, so median nerve, brachial artery, ulnar nerve. You can actually, when you go further up, you are actually in the axilla, and you can see the various other nerves, including the radial nerve. So I'm going distally, and you can see the ulnar nerve. Okay, now between the cubital tunnel. So this part, it's a bit tricky because it's difficult to negotiate the probe at this area. It can slip off the bones. So just need to fix your hand somewhere and then just closely manipulate it. Okay, or sometimes you may have to use both your hands just to make sure that you're fixing it properly. You can see that. Okay, so I'm going proximally. Okay, I'm going distally. So it's across the. Okay, then I'm going further down. You can see the ulnar nerve. Okay, so somewhere midway or distal aspect of the forearm, you can see the ulnar artery, which is a branch of the brachial artery. It comes and joins the ulnar nerve. So this is the ulnar artery and the ulnar nerve. And when you go distally, can you see this thin fascicle which comes out of the ulnar nerve? That's actually the dorsal cutaneous nerve. Okay. And this is ulnar nerve. I'm going distally. Now in the hand, and here is the Guyon's canal. Okay. So this is the Guyon's canal. So again, I'm keeping the arrow on the ulnar nerve. I'm coming proximally, proximally, proximally. Okay, this is ulnar artery which is going away from the nerve to join the brachial artery, and then the ulnar nerve here. Then a cubital tunnel. So it's a bit difficult, like I mentioned before. Just fix with both your hands and go proximally, and you can see it going to the medial aspect of the brachial artery. Okay. Now the ulnar nerve, like the median nerve, the carpal tunnel syndrome is the commonest entrapment neuropathy of the upper limb. The second commonest is cubital tunnel. Okay, but what you also need to understand is that there are many potential sites of compression of the median of the ulnar nerve close to the elbow. Okay, so the ulnar nerve, it actually in the upper arm, it's in the flexor compartment. Okay, so it's in the flexor compartment. So the arm, if you look, it's divided into anterior compartment and posterior, or flexor and extensor. And what divides it is the medial intermuscular septum on the medial aspect and the lateral intermuscular septum on the lateral aspect. Okay, so the ulnar nerve is on top or anterior to the medial intermuscular septum in the proximal arm, but somewhere lower down, from the anterior compartment, it goes into the posterior compartment. So it is difficult to see and appreciate it here, but if the nerve is entrapped at that site, you can actually see a sudden change in caliber. Okay, so this is one potential site of compression where the nerve actually pierces the medial intermuscular septum and enters the posterior compartment. Okay, and once it's in the posterior compartment, it actually lies posterior to the medial intermuscular septum, medial to the, just medial to the triceps muscle. So I'm just going to ask Anita to extend. Okay, extend. Okay, extend. So that's the triceps muscle. So this triceps muscle forms the lateral wall of it sits on the triceps muscle. Okay, so from anterior compartment, it pierces the intermuscular septum. It lies posterior to the intermuscular septum and very close to the triceps muscle. And sometimes you may have a fascia which starts from the medial intermuscular septum and joins the triceps muscle. Okay, so this is called the arcade of Stuthers. So there's an arcade of Stuthers, unlike the ligament of Stuthers, which causes median nerve entrapment. You can have an arcade of Stuthers which can cause an ulnar nerve compression. Okay, so the first potential site is the medial intermuscular septum. Then the second site of compression is the arcade of Stuthers, and then finally, which is the commonest cause, is the cubital tunnel. Okay. So in cubital tunnel, what happens is you can see these two bones. Okay. So this is the olecranon here, and this is the medial epicondyle, and this is the median nerve. Okay. So there can be a fascia between these two. That's called the cubital retinaculum. Okay. So when I go distally, the median nerve, it dips below the two heads of the flexor carpi ulnaris. So it dips between the two heads of the flexor carpi ulnaris, and then it lies below the flexor carpi ulnaris and superficial to the flexor digitorum profundus. So I'm going to ask Anita to again flex her little finger so you can see this. So this is the flexor digitorum profundus, and at the wrist, can you flex like that? Okay, so you can see all the muscles contracting because it's flexion. So I'm just going to ask her to contract ulnar in an ulnar direction. Okay. So again, it's a bit difficult to appreciate. Okay, so the muscle anterior superior to the ulnar nerve is the flexor carpi ulnaris, and inferior to that is the flexor digitorum profundus. Okay, and here I'm going distally, and you can see that the dorsal ulnar cutaneous nerve, it moves branches away from the ulnar nerve to supply the dorsal aspect of the hand. And then let me show you the Guyan's canal. Here I am going distally, and you can see the ulnar nerve and ulnar artery, and this is the Guyan's canal. Again, it's a bit difficult to appreciate. Okay, so this is the ulnar nerve. Okay, so this is an ulnar nerve. So here you could get a compression to the ulnar nerve if there's any damage to the two bones, that is the hook of the hamate and the pisiform. Okay, or you could get a ganglion which comes from underneath, which can compress onto the nerve and cause ulnar neuropathy at the wrist. Okay, so this is also important. So the ulnar nerve, once you reach the hand distal to the Guyan's canal, it divides into two branches, the superficial and the deep. The deep branch, it goes and supplies all the intrinsic muscles of the hand, whereas the superficial branch, it goes and supplies the skin of the little finger and ring finger. So sometimes when I go distally, you can see, let me just, okay. So one easy way to identify these digital nerves or these tiny nerves in the hand is that they usually go along with the blood vessel. So this one here, this could be the superficial branch of the ulnar nerve. Okay, so you can see all these tiny branches. Okay, so now to recap again, the ulnar nerve, it lies medial to the brachial artery, then it is in the anterior compartment in the proximal arm, but when I go distally, it pierces the intermuscular septum and it lies in the extensor compartment or posterior compartment. It lies underneath the medial intermuscular septum, and it can be covered by continuation or extension of the medial intermuscular septum, which goes to the triceps. And this extension, if it's seen, is called the arcade of Struthers. So this is the second potential site. And then when I go distally, it can get compressed between the flexor retinaculum, which is a ligament from the medial epicondyle, to the olecranon. Okay. Then even distally, when I go, the nerve actually, when you look at the flexor carpi ulnaris, it has two heads. Okay, one goes to the medial epicondyle and one goes to the olecranon. Okay, so between these two heads, sometimes there can be a fascia, which is called the Osborn's band. So there can be a compression of the ulnar nerve underneath this Osborn's band, or between the two muscular heads of the ulnar nerve. I mean the flexor carpi ulnaris. Okay. So the flexor carpi ulnaris here, when it comes towards its attachment in the medial epicondyle and olecranon, it splits into two tendons. So two muscular bellies and two tendons. It can get compressed between the tendons, or it can get compressed between the muscular bellies. Okay. So there are actually 4-5 potential sites of compression of the ulnar nerve at the elbow, and that's why you need to do inching studies. One of the purposes you do inching studies in ulnar nerve neuropathies at the elbow is to find out where the site of compression is. Okay, so that's about ulnar nerve. Now let me go to the radial nerve. Okay, so the radial nerve is, unlike the median nerve and ulnar nerve, the radial nerve is quite tricky to scan because number one, the location. Okay, so it's the posterior aspect of the arm, and also it starts from the axilla, then it winds around the humerus, then it comes to the anterior compartment, then distally it goes into the posterior compartment, and then it runs on the posterior aspect. So it's got a very spiral course. That's number one. Unlike the median nerve and ulnar nerve, which has a very longitudinal and direct course, the radial nerve, it has got a very spiral course, and sometimes it can be quite difficult to actually manipulate your probe and hand and actually go along the nerve. Okay, so that's number one. Number two is that the radial nerve, unlike the median nerve and ulnar nerve, it splits into many different branches. So actually the radial nerve, it winds around the spiral groove. So let me show it to you. Okay, so again, now, like I mentioned before, if all you need to do is find out the fascia between the muscles, and you look for any hypoic structure within that fascia. So this is the radial nerve. Okay, so this is one muscle, second muscle, and you can see fascia, and these two structures is the radial nerve. Okay, I'm going proximally. So it's one single nerve with 2 or 3 fascicles. So when I go distally, you can see it splitting into 2 different branches. Okay, so this is where you have the branching of the radial nerve into the posterior interosseous nerve, or the deep motor branch, and the superficial radial cutaneous nerve. Okay, so the radial nerve in the distal arm, it splits into 2. The deep motor branch and the superficial radial cutaneous nerve. So the deep motor nerve, it goes between the 2 heads of the supinator muscle. Again, quite difficult. It's a very tiny nerve between the 2 heads of the supinator muscle, and then it goes to the, you can see the location of my probe, it goes to the extensor aspect of the forearm. Okay, once the nerve is in the extensor aspect of the forearm, it actually explodes into many different branches. Unlike the median nerve, where branches go at particular levels, the radial nerve in the forearm, it actually splits into many different tiny branches which are unnamed, and it goes and supplies the distal muscles. Okay, so that's another reason why the radial nerve cannot be sometimes seen all the way down to the wrist. Okay, so the deep motor branch of the radial nerve, once it enters between the 2 heads of the radial nerve and exits the supinator muscle, that's when it's called the posterior interosseous nerve. Okay, so the posterior interosseous nerve is a direct continuation of the deep motor branch, except that it's renamed once it reaches the posterior aspect of the forearm. Okay, so I'm just going to ask Anita to supinate. Oh, just 1 second, let me fix the probe. Can you turn your palm facing up towards the ceiling? Your palm like that. Okay, now the other way. So you can see the supinator muscle contract. It's nicely seen. Okay, so this is where the radial nerve deep motor branch can get inflamed. Okay, so I'm going proximally, and you can see, you can relax, and you can see that it forms the radial nerve. Okay, so the radial nerve again splits into 2, and what I'm going to do now is follow the superficial radial cutaneous nerve. So this goes to the between the 2 heads of the supinator, whereas this one goes distally. Let me do it again so that you can have a clear picture. Goes distally, and here you see this pulsating thing. That's a radial artery. Okay, so this is a superficial radial cutaneous, and this is a radial artery. So this is a superficial radial cutaneous nerve. It goes underneath the brachioradialis muscle and on top of the extensor carpi radialis longus. Okay, so the superficial radial cutaneous nerve, it runs distally underneath the brachioradialis, and superficial to the extensor carpi radialis longus, and somewhere in the distal forearm it pierces the superficial fascia here and becomes cutaneous. Okay, so this is also a potential site. So you may get a compression not only in osteofibrous fossa, but you can get a compression of the nerve even when it exits from the it becomes superficial. You know, it can get compressed in the facial plane also, the subcutaneous facial plane. Okay. Now another thing is, in some patients actually the posterior interosseous nerve, instead of dividing into multiple different branches, it may just divide into two branches, which is the descending branch of the posterior interosseous nerve and the recurrent branch of the posterior interosseous nerve. So sometimes you may be able to identify the nerve which goes distally, but here I'm not able to do that. Okay, so I'm going proximally. You can see that I'm winding the probe from posterior. When I reach the elbow, it becomes anterior, and then again you can see that it goes posterior. I'm winding my hand. Okay, and here the nerve is on the spiral groove. Okay, so once it's out of the spiral groove, from posterior compartment of the arm, it comes into the anterior compartment of the arm. Okay, so here the nerve actually pierces the lateral intermuscular septum. So from the posterior compartment, it enters the anterior compartment by piercing the lateral intermuscular septum. Okay, so this is where the nerve can get kinked, or it can get caught when there's a fracture of the humerus. Okay, so here the nerve is relatively fixed. Okay, so this is also a site where you can get fraction injury of the radial nerve. So you go distally once it's in the anterior compartment, and when it splits into two branches, this area, I mean this length of the nerve, actually this is where the nerve is in the radial tunnel. Okay, so like you have carpal tunnel, cubital tunnel, you also have a radial tunnel, and the radial tunnel, the wall is medially it is the brachialis muscle, and laterally it is the brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis. Okay, so that's the lateral wall, and it splits into two, deep motor branch and superficial radial cutaneous. And here also there are potential sites of compression, one being the lateral intermuscular septum. Then it can get compressed when there's a fiber, the fascia of the brachioradialis is very thick. It can get compressed underneath that. Then it can get compressed underneath the flexor carpi radialis brevis. And then here, when the deep motor branch, it goes between the two heads of the supinator. This is the supinator canal. Okay, so the radial tunnel is there, and then you have a supinator canal between the two heads of the supinator, and this is also a potential site of compression, either within the canal or, more importantly, when it just exits the canal. Okay, so you need to look at the radial nerve. When a patient comes to you with wrist drop or finger drop, you need to look at the radial nerve closely in all these areas. Exit from the supinator canal, within the supinator canal, within the radial tunnel, whether it's compressed beneath the brachioradialis, extensor carpi radialis brevis, and sometimes you may have a lot of blood vessels here, which is called the leash of Henry. Okay, so you can get a lot of blood vessels which can also compress the radial nerve. So I'm going proximally. This is spiral groove, and then you can see that if I were to trace this, you would see that this nerve goes all the way and becomes and it goes to the posterior aspect of the brachial artery. Okay, so this is the radial nerve. So hope I'm clear with all the nerves of the upper limb. I spoke about the median nerve, I spoke about the radial nerve, and I spoke about the ulnar nerve. Okay, so let me just show you my presentation, and then I'll come back to the lower limbs, and then maybe we'll wind up. Thank you, Anita, again. Okay, so what I will do now is, when you ask for ultrasound, you should have a clear reason as to why you're asking an ultrasound. So you see a patient who's got a neuropathy or a muscle disease, you examine the patient, you come up with some differential diagnosis, you do nerve conduction studies, you do a functional assessment of the nerve. But if you want to do a morphological assessment of the nerve, you have to do imaging studies. So that can be done either by ultrasound or by MR scans. Okay, but ultrasound is much more easier to do. It's cheaper, and importantly, it is like a point of care. The patient walks into the clinic. If you have a good machine, you can do the nerve conduction studies immediately, and you can do an ultrasound immediately. You don't have to book the patient for the MRI scan. He does not have to come back. So it's like a one package. You do everything for the patient. Okay. So when you see a patient with a neuropathy or muscle disease, and you ask for ultrasound, you should know why you're asking it. You should know when you would want it. You should know how to do it, and you should also know what you're looking for. Okay, so always ask why, when, how, and what. Okay, so why do you do an ultrasound? How is it important, or how is it better than other diagnostic modalities? So number one is that it has got a very high soft tissue resolution. So if you were to see the images of nerve ultrasound and compare it with MR scan of the nerve, you'd be surprised that the ultrasound is much better than MRI scans, because it has got much higher resolution. The nerve looks huge in ultrasound, whereas in MR scans you actually need to hunt for the nerve. Okay, so that's one reason why ultrasound it's becoming widely used, because the ease with which it can be done, and secondly the ease with which the nerve can be found out. And secondly, you can scan the entire length of the nerve, right from the wrist, elbow, all the way to the shoulder. You don't have to send the patient to the MRI and ask for MRI shoulder, elbow, hand. So with one single modality, spending just half an hour, you can scan the full length of the nerve. Then you can do real-time dynamic evaluation of nerves. One thing which I didn't show here is that, which I actually forgot to show, is you can actually show subluxation of the nerve, ulnar nerve, the cubital tunnel. You can show compression of the median nerve by various tendons and muscles in the carpal tunnel. So by changing posture of the hand or elbow, you can actually do a real-time evaluation, dynamic evaluation of the nerve. Okay, some nerves are prone to compression with certain positions. Most of the nerves that's why patients in carpal tunnel develop nocturnal symptoms, or that's why patients with cubital tunnel, they have symptoms worse with flexion at the elbow. When you flex the elbow, the nerve is compressed more between the cubital tunnel, retinaculum, and actually you can do dynamic studies and see whether there's further constriction of the ulnar nerve. Then, of course, most importantly is you can compare with the opposite side. Okay, you can compare any nerve with the opposite side, unlike MR scans where you need to ask the patient for an entirely different scan. In ultrasound, you can just do it one shot and you have an answer. And this comparison will help with the diagnosis. Then, of course, it helps with certain diagnostic and therapeutic decisions. For example, a patient who comes to you with recurrent carpal tunnel syndrome, you can look at the median nerve for focal constriction, and it can be of use. Then there are some technical advantages. One, it is portable. You can just bring the machine to the patient and you can do the scan. It is much more cheaper, it's faster. And in those patients who are not eligible for MR imaging, patients who are sick, patients who have metal implants, patients who have various orthotic devices implanted, this can be of much more use. So that's why you need to master this technique. Then when do you use it? Okay, so normally when we see a patient with focal neuropathy or myopathy, or that matter, any kind of neuropathy, you ask history, do a physical examination, do a neurological assessment, do investigations, and then you do electrodiagnostics, and finally you ask for imaging studies. The basic purpose is that you actually need to find out a pattern of disease, whether it's a large fiber, small fiber, sensory, motor, and then based on that you formulate your differential diagnosis. Okay, so if I see a patient who's got thickened nerves, a patient with diffuse peripheral neuropathy or polyneuropathy who's got thickened nerves all over, I would think of a demyelinating neuropathy rather than axonal. Okay, so it would also help in formulating your differential diagnosis. Now, the ultrasound can be of use if you look at what we deal with. Neuromuscular specialists, we deal with disorders of the anterior horn cell, root, peripheral nerves, neuromuscular junction, and muscle. And if you look at ultrasound, it is useful in anterior horn cell disorders. It is very useful in peripheral nerves. Not much used in neuromuscular junction as of now, but with time it may change, and it is becoming more and more useful in muscle disorders. Okay. So what are you looking for in anterior horn cell disorders? You're looking for fasciculations, you're looking for muscle atrophy, you're looking for changes in muscle echogenicity. In peripheral nerves, I'll be talking to you again in detail after a few slides. Neuromuscular junction, not of much use now. And in muscle disorders, you are basically looking for muscle wasting. You can look for changes in muscle architecture. And sometimes you can look for selectivity of involvement. If you look at the various dystrophies, they tend to selectively involve certain muscles. So if you do an ultrasound, you can actually see whether the pathology is confined to a selected group of muscles, and then again it's useful in differential diagnosis. So for neuropathies, it's most useful in entrapment neuropathies. Okay, so I would say it's most useful in mononeuropathy. So if you have polyneuropathy, mononeuritis multiplex, and mononeuropathy, in mononeuropathies you tend to see structural or morphological changes the most. So it's quite useful in mononeuropathies or entrapment neuropathies. Okay, then it is definitely of use in traumatic or post-operative neuropathies. It is of use in inherited neuropathies, in demyelinating neuropathies. All the peripheral nerves tend to become enlarged. Useful in infiltrative neuropathies like in neurofibromatosis or like in neurolymphomatosis, you can see enlargement of the nerves. Infective neuropathies like in leprosy, these nerves are enlarged. Not of much use in metabolic, nutritional, or toxic induced. Okay, so it's actually useful in many of the neuropathies that we actually see. Okay, so this is a video of just showing the usefulness of muscle ultrasound. This is a patient with motor neuron disease. You can see fasciculations. Okay, so what you need to compare is this is a huge muscle. You're looking at the quadriceps. Okay, and the field of view is very wide. Unlike a needle which has a tiny area of pickup, a few millimeters, less than a couple of centimeters, you do a muscle ultrasound, you can see the whole muscle, you can see the deeper part of the muscles where the needle may not be accessible. So it is, I would say it is extremely useful in detecting fasciculation, especially in some muscles like paraspinal muscles, abdominal muscles, it is of use. Tongue, it is of use. Okay. Now in muscle diseases, there are various patterns. Normally you get the starry sky appearance. Okay. So in some patients, especially in dystrophies, this muscle is replaced by fat or by fibrous tissue, and you get a very hyper echoic top layer, and below that the sound waves don't go down and it becomes hypoechoic. So you get you can actually make out dystrophies based on the echogenicity. Okay, so if the muscle is replaced by fat and connective tissue or fibrosis, and then this change in the echogenicity. Sometimes you can see calcifications, and sometimes in certain neurogenic conditions you get what we call this moth-eaten appearance, where there is wasting of some of the motor units and some of SPAD. So some patchy areas where you get hyperechoic areas and some areas where the muscle architecture looks good. So multiple different patterns of echogenicity in the same muscle giving you a moth-eaten appearance can be seen in chronic neurogenic or even in myopathic disorders. Okay, now how do we do it? This is the most challenging. I mean, especially for people who have just started doing ultrasound. I would say it is the most challenging part of the evaluation. Okay, so when you start doing it, you need to pay attention to a few things. One are technical aspects, and then the anatomical aspects. So technical aspects basically you should know about the probe you're using. So the probe, if you look at the probe, thank you. So if you look at the probe, it's very important that this is actually the main part of the machine, okay? The main part of the machine, and you can see that if you look at this part, you can see what hertz is it, okay? 4 to 14 hertz, okay? Then based on the shape of the probe, you can have curvilinear probes, you can have phase array probes, linear array probes. So there are many different types of probes which can be useful in different conditions. Then you should know about the machine also, okay? So the probes, coming to the probes, you have high frequency probes for superficial nerves. So high frequency means this number here, megahertz, is more, okay? Low frequency, it's much lesser megahertz. The high frequency probes can be used to assess the superficial nerves. It has high resolution, but unfortunately the penetration of these waveforms are much less compared to low frequency. Okay, so if you want resolution, you go for high frequency. If you want penetration, you go for low frequency. Then you should know about the machine. So the machine, number one is you should know what mode to use. Okay, so what I've been using so far is the B mode. So the brightness mode. So this is most important to look for the morphology. Okay, then you have motion mode. For example, you want to look at the diaphragm, or you look. M mode is basically what you use in cardiac echography to look at the valves. Then you have color flow mode, power Doppler. These all are for vascular imaging. Okay, and this is the big headache. When you see a machine, you have all these knobs, and you don't know what knob is for what. Okay, but with time you'll get used to it. So if you're able to master this, actually you will be quite good in ultrasound. Okay, and this is what we do with the knobs. So we make if we know about all these things, the gain, the depth, the zoom, all these things, image which was actually not good, if you're able to manipulate all these knobs, you can get a high quality image. So know about the machine, it's very important. Now the anatomical considerations, of course, you should be very good with anatomy. You should know what are the underlying pathophysiology for the various disorders, and then you should have some idea of the histology also, because ultrasound is basically you're looking at the ultrastructure of the nerves or the muscle. Okay, and what do you look for? In nerves, you're looking for cross-sectional area, shape, fascicular architecture, vascularity, mobility, and course. And for extraneural, you should also look outside the nerve for facial compression, for osteofibrous compression, so compression within the facial planes, compression within osteofibrous tunnels. You should look for bony defects like in cubital tunnel, there can be loose articular bodies in the elbow joint which can cause neuropathy. You should look for tumors. You should look for muscle and tendon pathologies, and you should look for vascular abnormalities. Okay, and for muscle ultrasound, again you have this starry sky appearance, and then with time you tend to lose this. Okay, so for muscle, again what basically happens is with muscle disease, there's a replacement of fat, this replacement of muscle fibers with fat and connective tissue. So you can do a visual analysis, or you can actually, with the recent machines, you can do mean grayscale or backscatter value analysis, and you can actually quantitate the amount of change in echogenicity. Then you can look at muscle thickness. There are many different calipers the machine has which can assess the thickness. Then look at the Doppler flow muscle movement also. Then these are some recent advances. Elastography to look at the mechanical properties of the muscle, which I'm not going into. Okay, so upper extremity median nerve, like I mentioned, the anatomy comes from medial lateral cord, it goes down medial aspect of the arm, it enters the forearm, 4 potential sites of compression, ligament of Stuthers, pronator teres, then flexor digitorum superficialis, and the carpal tunnel. Okay, this is the ligament of Stuthers. If you see a proximal neuropathy, median neuropathy, ask for an X-ray. Ultrasound also helps. You can see the spur here, and you can see this. Sometimes you can see this ligament which goes down. Okay, ulnar nerve, it goes from anterior to the posterior compartment, and then it winds around the this medial epicondyle olecranon, the cubital tunnel. It goes inferior or dorsal to the flexor carpi ulnaris, and this is the gluteus scala. Okay, so this was where I was mentioning about the potential sites of compression of the ulnar nerve, arcade of Stuthers, medial intermuscular septum, cubital retinaculum, arcade of Osborn, and flexor carpi ulnaris. Okay, this is inching studies. Okay, so radial nerve, spiral groove, and distally between the radial tunnel and the supinator tunnel. Okay, so this is actually the supinator tunnel. Oh yeah, this is something which I did not mention. The proximal aspect of the supinator tunnel can have a very thick fibrous tissue which is called the arcade of Frost. So here also the radial nerve can get compressed. Okay, now, so it's important that you know the anatomy of the elbow, because this is where most of, if you look beyond carpal tunnel, this is where most of the entrapments happen. It's at the elbow level. So if you're very good with your elbow anatomy, and if you know various where the nerves are, where the muscles are, you should be good with ultrasound. Now let me go to the lower extremity. Okay, sorry.
The presentation?
Yeah, I'll go to lower extremity. I may be overshooting that.
No, no, it's fine. There was a question about if you can show axillary nerve.
Okay, axillary nerve, it's on the posterior aspect. I've had one patient with, the axillary nerve, it comes out from the quadrilateral space. It's a very short nerve, okay? And you're not able to access the nerve in its longitudinal plane. You're seeing a nerve which is coming towards you. So it can be quite tricky with the ultrasound probe. Normally what I do is I look at the muscles that it supplies, teres minor and the axillary, the deltoid, and based on that, with additional help for nerve conduction and EMGs, I make a call that it's a axillary neuropathy. But if you ask me whether I've seen the axillary nerve, no. But I think with time I should be able to appreciate it better. Could be one reason could be because I'm not seeing enough patients with axillary neuropathy. Unlike median and cubital ulnar, I hardly get any axillary, maybe once a year, and then it's quite difficult to fish out the nerve in such situations. Okay, so lower limb again, it's the same principle. You do a clinical localization, EMG studies, and ultrasound. So localization, there are certain key muscles. Okay. So, for example, if you have a patient who has weakness of the gluteus muscle, knee, hip extension is weak, you are talking about a pathology which is at the sacral plexus. It cannot be sciatic nerve. It has to be much proximal. Okay. So again, you have to be very good with your anatomy, and importantly, you should know which muscle is supplied by which nerve. Okay, so gluteus muscle is not the sciatic nerve, it is much more proximal, so think of the sacral plexus. Okay, the same way, short head of biceps femoris is supplied by the common peroneal nerve. Okay, so this is only muscle in the thigh, posterior thigh, the hamstring muscle, which is supplied by the common peroneal nerve. Okay, then lower down, it's the posterior compartment of the leg. So here it's a tibialis posterior. If you have tibialis posterior denervation and tibialis anterior denervation, you are dealing with the L5 radiculopathy. So there are a few key muscles that you should be knowing about and how it helps with differential diagnosis. And in the same way, anterior aspect of the thigh, if you have weakness of hip flexion and knee extension, of course it's femoral nerve, but hip flexion, you think of a pathology which is happening in the pelvis. If it's at the inguinal level, it would not normally affect the hip flexion. Then in the feet, it's the ADQP, okay, the abductor digiti quinti minimi, which is a muscle which is supplied by the lateral plantar nerve, and it can be selectively involved in lateral plantar neuropathies. Okay. Then it's important that you know the various sensory dermatomes. Then of course electrodiagnostic studies. Okay, so let me go now. These nerves, again, I get a lot of referrals to evaluate iliohypogastric, ilioinguinal, and the lateral femoral cutaneous nerve. It can be difficult, but sometimes you can see a focal neuroma, okay, especially in patients who have hernia repair, hernia surgery, and then they come with lower abdominal pain. Sometimes you can visualize these nerves and you can see a focal neuropathy. Now these nerves, the superior gluteal nerve, inferior gluteal nerve, cannot be visualized. I have not seen them. Okay. Now obturator nerve is also something which cannot be visualized. Now coming to the lower limb, let me start off distally. So the lower limb, so you have the thigh, you have the, I'm using the same logic, you have the thigh, you have the leg, and then you have the foot. Okay, so the anterior thigh is by the lumbar plexus. The posterior thigh and all the muscles below the knee is the sacral plexus. So anterior thigh, lumbar plexus, posterior thigh, and all the muscles below the knee is the sacral plexus. So just by doing a very simple examination, you can find out which nerve is involved. Okay, so let me, I'm going to start off distally, because you know these nerves, they are quite deep. They are under some of the biggest muscles in the human body, so it can be quite difficult to visualize. But it has been seen. I mean, I've seen the sciatic nerve from the mid-thigh downwards. The tibial nerve also can be quite difficult to see sometimes. Number one, it can be quite small, and number two, it's underneath two bulky muscles, which is gastrocnemius and the soleus. Okay, and the most useful nerve to evaluate using ultrasound in the lower limb is the common peroneal nerve. Okay, so we get a lot of referrals for foot drop, and it's not uncommon that we pick up ganglion. Every once in 3-4 months, we do pick up a ganglion causing foot drop. Okay, so I'll go to the ultrasound. So I'll start off with the common peroneal nerve. Okay, so the landmark is, if you are unsure, look at the area where the nerve is most likely to be seen The lower limb, if you're looking at the peroneal nerve, we all know that the peroneal nerve winds around the fibular head. So just palpate the fibula, which is the most prominent bony part of the lower extremity on the lateral side. Then just go above that, and you can see the honeycomb pattern, isn't it? So this is a honeycomb pattern. So this is a peroneal nerve. Okay. Then you go distally, or you go proximally. I'm going up the thigh. And here you can see the peroneal nerve. When I go proximally, you can see that it comes and joins the tibial nerve. So this is a peroneal nerve, comes and joins the tibial nerve. Okay. So peroneal nerve, tibial nerve. Okay. So now I'm going underneath the fibula head, and I'm going to the anterior aspect of the leg. Okay. So here again, what happens is there's a abrupt change in the course of the nerve. Okay, so from something which was very linear and continuous, which is going down, it's dipping. So the course of the nerve changes. Okay, so from a linear course, the nerve dips down. So it's very easy to lose the nerve here, because you're not seeing the nerve in its axial plane. Okay, but if you pay close attention, what you need to look at is the nerve, superficial peroneal nerve and the deep peroneal nerve. So the common peroneal nerve just below the fibula head, it divides into the superficial and deep peroneal nerve. The superficial peroneal nerve lies below the peroneus longus. So I'm going to ask Anita to evert. Can you evert? Okay, evert. Evert. So that's the peroneus longus muscle. So again, if you're unsure, what I normally do is I go distally and the nerve becomes superficial. Okay, so one anatomical point where the nerve can be easily seen as the fibula head. The second anatomical point is the distal 1/3 of the leg, where the nerve actually pierces the facial plane and becomes subcutaneous. So you can see this. So this is a superficial peroneal nerve. So what I do, I go proximally. I can see the nerve. It's a bit difficult to see. I go proximally. Here you may have to do some kind of imagination, and you can see that it's going up. Okay, so that's the nerve. Okay, so if you are unable to trace the nerve from proximal to distal, you go and find the nerve distally, and then you go proximally. Okay, so that's what I normally do. So this is where the nerve can get potentially compressed. Okay. In most of the foot drop patients that I see, especially patients after chemotherapy or patients who have lost a lot of weight, we get a lot of patients who come to us with foot drop. But we do an ultrasound. Basically, we just want to make sure that we are not missing a structural problem which can cause the neuropathy. And most of the time, the neuropathy is because of external compression. So you may not see much actually of the peroneal nerve. Okay. Now the superficial peroneal nerve, like I said before, it goes under the peroneus longus. The deep peroneal nerve, it goes under the extensor hallucis or extensor digitorum longus. So can I get you to? So that's there are two muscles that are here, the tibialis anterior and the extensor digitorum longus. Okay. Do you think you can extend the toes without the foot? Okay. So this is the extensor hallucis longus. Okay. So you can see it beautifully. The nerve usually tends to lie underneath that, and it always goes with the tibialis anterior So it has to be somewhere here. So this is the nerve. Okay. So just see the extensor digitorum longus. Look underneath that. This is the septum, and this is the nerve, arterial nerve. Okay. And like I mentioned before, if a patient has got a common peroneal neuropathy, there is loss of architecture of both the tibialis anterior and the peroneus longus. If there is a pathology confined to the deep peroneal nerve, these muscles, tibialis anterior and extensor digitorum longus, they show pathological changes or sonographic changes. Whereas if it is isolated superficial peroneal nerve, you can see pathology or sonographic changes in the peroneus longus. So lower down, so this is the common peroneal nerve, deep peroneal nerve, superficial peroneal nerve. Now this is also a area of compression when it comes out of the facial plane. It's a very I've seen a few patients who come with severe pain over the foot, and I've seen entrapment here. It's not uncommon. And then finally, this nerve, when you place it distally, you can see it all the way to the distal aspect. Sometimes you can see it up to the forefoot and up to the toes. Okay, so here the nerve becomes the medial and the intermediate dorsal cutaneous nerve. So the superficial peroneal nerve, once it reaches the dorsum of the foot, divides into two, medial dorsal cutaneous and intermediate dorsal cutaneous, okay, which supplies the skin over the dorsum of the foot except for the first rib space. Now the deep peroneal nerve, let me see again. So basically I'm focusing on this blood vessel and this nerve. I'm focusing there to see whether something is coming up. You can see something coming up, a bit difficult. Yeah, you can see it actually here. So this one here, the nerve again, if you're unsure, you can look at the dorsalis pedis and go proximally. So the nerve is close to the dorsalis pedis. So the deep peroneal nerve again splits into two, medial and lateral. The lateral supplies the EDB, the extensor digitorum brevis, and the medial it goes and supplies the first rib space. Now let me show the tarsal tunnel. Okay, so can you switch facing this side?
This way?
Yes. Okay, so the tarsal tunnel, any patient presenting to you with forefoot pain, forefoot numbness, medial foot pain, lateral foot pain, okay. So here it's easy to identify because if you look at this, the nerve, it goes with the anterior tibial or the posterior tibial artery and the posterior tibial vein. Okay, so one posterior tibial artery and two posterior tibial veins. It gives you a traffic light appearance, three dark hypoechoic structures, and then you can see this honeycomb pattern. So this is the posterior tibial nerve. And go ahead distally. It splits into the medial plantar and the lateral plantar. So sometimes you can actually see it going distally or almost to the, if you place close attention, you can see the nerve going distally. Okay. So tibial nerve again, you can see it dipping down, and then it goes underneath the soleus and the gastrocnemius. So it's quite a deep nerve, and sometimes it's quite difficult to, but here you can see when I go to distal to proximal. Okay. here the tibial nerve, it splits into the medial plantar, lateral plantar. The medial plantar nerve, it goes underneath this muscle here is the abductor hallucis, and this muscle here, is it a muscle? This muscle here is the flexor digitorum brevis. So it goes in between these two muscles. So it can get entrapped here. Okay. Whereas the lateral plantar nerve, it goes underneath the flexor digitorum brevis, and then actually one of the proximal branches of the lateral plantar nerve is called the Baxter's nerve. It supplies the abductor digiti quintae minimi. So if a patient has got pain over the lateral foot and you do an EMG and there's isolated involvement of the abductor digiti quintae minimi, you think of a Baxter's nerve. Then you can also identify the calcaneal nerve, medial calcaneal nerve sometimes, and more importantly, the tunnel. Sometimes you can see all these tendons. Okay, so you have tendons from the tibialis posterior, you have tendons from the flexor hallucis longus, flexor digitorum longus. So 3 different tendons, and if you have tenosynovitis of any of these tendons, this pressure on the tibial nerve. Okay, sometimes you can have varicose veins and a lot of vascularity within the tarsal tunnel. That can also cause tarsal tunnel. Okay. So lower limb, I've spoken about the posterior tibial nerve. I mean the tibial nerve, mainly the distal part where it can be entrapped in the tarsal tunnel. I've spoken about the medial plantar nerve. I've spoken about the lateral plantar nerve. Then the common peroneal nerve at the fibula head. Then I've shown you how the 2 nerves divide into superficial and deep, and the superficial entrapment of the superficial peroneal nerve in the distal aspect of the leg. And you can, if you are good enough, you can actually see the superficial peroneal nerve and deep peroneal nerve all the way to the tips of the toes. Not the toes, to the dorsal forefoot. Okay. Now the other nerve in the lower limb is one common nerve is the myalgia parasitica, which is extremely difficult. I find it difficult to visualize, even though it's described well. Just maybe a few times I've seen it, but more importantly, it's quite difficult to see in patients who are obese. Slight obesity, these nerves become quite difficult to visualize, and they have a very varied anatomy. It may not go exactly on the same side. It changes position, and it's quite difficult to see. And then the femoral nerve in patients who have weakness of hip flexion or who's got weakness of knee extension, especially after any kind of procedures, angiogram. I look at the inguinal area to look for any pseudoaneurysms or any of those things. Okay, so I've spoken about the lower limbs. I've spoken about the upper limbs. I've given a brief idea about what happens in muscle diseases. I've spoken about anterior horn cell disease. Basically, you're looking for fasciculations. Sometimes it can be easier to pick up fasciculations using an ultrasound probe compared to needle examination. Then you should look for muscle wasting and all these things. Okay. Other things I've not dealt or gone into is nerve vascularity. For that, you need to see a patient who's got a disease. Only then it becomes obvious. Then to look at, to show actual pathology. Unfortunately, with the ongoing COVID, we don't have easy access to our patients. So that's another reason why I could not get the patients. Okay, hope this was informative. See you soon. Thank you. Thank you to Anita and Michael.
Thank you, Dr. Joy. Pleasure.